My lecture for today will be on role of surgery or antibiotics in septic arthritis and osteomyelitis. There's a very famous article by Scott Cosin et al. On musculoskeletal infections in children, where he has said antibiotics save the life while surgery saves the bone. A couple of examples regarding it. This is a 3-year-old female hospitalized within 48 hours of symptoms of fever, pain, and swelling. Has a large swelling over the distal femur. MRI suggests an osteomyelitis with a subperiosteal abscess. It was drained within 6 hours of MRI, treated with antibiotics, and at 1 year has full range of motion and no sequelae. As against that, this was another child, a 3-year-old child, presented 18 days after initiation, developing symptoms, initially treated only with antibiotics, comes with a huge pathological fracture with a big sequestrum, and after a long course is still having discharging sinuses. These two contrasting cases gives us a corollary to this, that is, antibiotics save the life, but surgery at appropriate time saves the bone. Septic arthritis and osteomyelitis are two of the true surgical emergencies in pediatric orthopedics, which is usually the result of a hematogenous seeding of the vascular synovium. One of the most important articles about pediatric osteomyelitis and septic arthritis is that by Trueta, which has explained this beautifully. And when we start treating it, we should know the aims of treatment. These aims should be control and eradicate infection, prevent the spread of infection to other contiguous and systemic sites, prevent progression of the infection to a chronic infection, and to prevent complications. Thus, treatment should be based on timely diagnosis, prompt surgical decompression, and effective antibiotics. We should remember that there are two components to this condition. One is a surgical problem, which is in a medical disease. Surgical problem is the bony involvement. The medical disease is the sepsis, which is always there. Hence, the surgical problem has to be treated with surgery and decompression, while the medical disease has to be treated with antibiotics. A very good article by Erklich et al. In JAOS 2021 describes this very beautiful figure about the involvement of the metaphysis in septic arthritis of the hip and the no involvement of the metaphysis in the septic arthritis of the knee. It also describes the surgical drainage in septic arthritis, which has to be performed with utmost urgency, preferably within 8 hours of onset, to prevent cartilage damage by inflammatory cells of the synovium, to reduce the stretch of the capsule, thereby preventing joint subluxation or dislocation, and in the hip, to minimize the risk of AVN due to tamponade. Surgery can be in the form of aspiration, open arthrotomy, or arthroscopic lavage. Aspiration, however, can be used only in a few doubtful cases. It is very effective in knee, ankle, and elbow, which are superficial joints, but not very effective in the hip. It can be used for obtaining fluid for culture, but should not be used in isolation, especially when it's a thick, purulent fluid, and may be combined with irrigation. The disadvantage is that it does not irrigate the joint, especially if it's a thick granulation tissue, may require multiple aspirations. And in case of the hip, it can be aspirated in two spots. One is through the Smith-Peterson approach, and second is through the subadductor region. Arthrotomy, however, is the surgical gold standard. In fact, negative arthrotomy is better than missing the bus and should be done as early as possible. Here, usually immobilization is necessary after an arthrotomy. The commonest performed arthrotomy is the hip arthrotomy, which has to be performed through the anterior Somerville approach, though sometimes a medial approach can be also used. It is the most definitive way of decompressing the joint for removal of the purulent material, especially the granulation tissue. And it has to be in the form of this sort of rectangular capsulectomy, which will help in effective decompression. Arthroscopic drainage does find a role in a few articles. Prasad has written 2 of them, which are landmark articles about arthroscopic drainage in very young children, in fact, as young as 3 weeks old. However, this can be attempted with a long learning curve and requires technical expertise as well as the equipment for it, and may not be suitable for general orthopedic use. What about osteomyelitis? Another excellent article by Harrick et al. Describes that unlike septic arthritis, osteomyelitis is primarily a medical disease. This is more seen in the Western literature. However, this big disclaimer is that at least until the abscesses are formed, in the early stages, treatment can be directed towards giving appropriate empirical antibiotics. However, surgical decompression has to be kept in mind, especially in failed initially antibiotic treatment, when there's a presence of large abscesses on MRI with concomitant septic arthritis. And usually it involves a cortical window with multiple drills in the metaphysis. It's the most important thing to prevent complications where there is a removal of subperiosteal collection and decompression of metaphyseal bone. How do we do it? Well, metaphyseal bone is the epicenter of the infection. Usually a cortical window is created here. Remember that it's very close to the physis, that your scooping should not damage the physis further. And it's important to immobilize the limb, especially at least for 4 to 6 weeks, because you have created a big cortical window in an already weakened bone. What about antibiotics? Well, initially it used to be very, very aggressive like Sehwag. Well, now we have become quite defensive. We know that it is a short course of antibiotics which are used especially for community-acquired infections. An excellent recent article it shows its initial IV antibiotic therapy only for 2 to 4 days. About 5 days is the maximum. After which we can shift over to oral antibiotics. Empirical antibiotics in most of the times are usually first and second generation cephalosporins. In special circumstances like sickle cell disease, you can use a different antibiotic. Well, hospital acquired or in cases where the community acquired MRSA population is more than 10%, then you have to use higher antibiotics like vancomycin and clindamycin. Well, duration of antibiotics initially it is for 5 to 7 days, after which it can be shifted over to oral antibiotics, which have to be continued for about 4 to 6 weeks. When do we shift over to oral antibiotics? Well, there is European Society of Pediatric Infectious Diseases has given the few criteria. The child has to be afebrile for 48 hours. There has to be a clinical improvement in symptoms, decrease in CRP to about 50% of initial value. It may not be complete normal. No signs of local or systemic complications. And if it's a non-viral strain, it can't be utilized when it's a MRSA or a Panton Valentine leukocidin positive MSSA strain. Thus, take-home messages. Acute bone and joint infections are surgical emergencies treated as such. Requires prompt drainage, decompression, and immobilization. In pediatric age, early surgery is important to save the bone. However, we should remember, as we have got better equipped and experience in managing these infections, so have the bugs we are fighting against. Beware of these weird drugs, the MRSAs, the Kingelas, and the MSSA and PVL positive drugs. Thank you very much.